Dear colleagues, a warm welcome to you all on this webinar on Central Serous Chorioretinopathy organized by EURETINA. My name is Camiel Boon and I'm a consultant ophthalmologist in Amsterdam University Medical Centre and Leiden University Medical Centre. We have quite a lot of attendees this moment and also for after viewing, and this also reflects, I think, the need for more information on this quite mysterious disease. We know that the disease is still surrounded by controversy and uncertainty, for instance, with regard to its pathogenesis, diagnosis, differential diagnosis, and certainly also the treatment. But fortunately, there are some recent insights that will really help us to grasp these aspects of the disease a bit better in our clinical practice. I'm happy and honored that a list of experts in the field were willing to join us and to contribute to the webinar. We will have 6 presentations of each 6 minutes that will cover the different aspects of CSC in a nutshell. And so the talks will be quite short to reserve as much time as possible at the end of all the talks to have a nice discussion based on all the questions that we receive via the Q&A chat. So please ask your questions via the chat and we'll try to address as many as possible. If there are too many questions to address in the discussion, we will try to also address the questions within the chat after the meeting, so you can look it up if there's an answer. So without further ado, I would like to start with the first speaker, which is Sekar Galuh from Indonesia and the Netherlands, who will talk about the experimental evidence on central serous chorioretinopathy pathogenesis. Enjoy.
Dear colleagues and chairman, ladies and gentlemen, thank you for the opportunity to contribute to this first EURETINA Digital Symposium. Today, I would like to share some experimental evidences on the pathogenesis of central serous chorioretinopathy, including the study that we found in our lab. I have no financial disclosure. Central serous chorioretinopathy, or CSC, is a common chorioretinal disease. Multimodal imaging, including indocyanine green angiography, or ICGA, is mandatory to establish its diagnosis. On OCT, subretinal fluid and usually a thickened choroid can be observed. On ICGA, imaging the choroid CSC is characterized with the hyperpermeability. The risk of CSC is increased with 2 major risks. First, male predisposition. Males are 6 times more likely to develop CSC than females, which indicates that sex hormones may play a role. The second risk is exogenous corticosteroid use as the most pronounced risk factor of CSC. This is interesting because corticosteroid use increases risk of CSC independent from route of administration and dosage. So now, what is the current experimental research evidence and how are these risk factors associated with CSC? There are still quite some unknowns, but we certainly have some clues. In the next slides, I will discuss with you some interesting related evidence. First, let's take a look on the underlying genetic risk. Earlier, we investigated if CSC is associated with age-related macular degeneration, or AMD, because they have overlapping clinical characteristics. We found that ARMS2, the gene that is increased risk for AMD, seems protective in CSC. We also found that complement factor H, CFH gene, is also associated in CSC. Systemic complement activation is shown in AMD, but we did not find this in CSC. So these findings indicate that CSC has different underlying pathogenesis than AMD. Second, endogenous hypercortisolism, for example, in the patient with Cushing syndrome, may show CSC-like abnormalities as it has been studied extensively by Elon van Dijk and Joe Springs, together with the endocrinologist. Interestingly, we measure hair cortisol concentrations to distinguish the short and long term of hypercortisolism, but we found no evidence to support this, so this warrants a further study. As I mentioned before, the exogenous corticosteroids use is a major risk too. Corticosteroids act in a cellular level, and to deliver a response, corticosteroids such as cortisol, aldosterone, and dexamethasone will bind to receptors, either mineralocorticoid receptor or glucocorticoid receptors, which depends on their ligand binding affinity. It still remains a question how these receptors regulated in CSC. Let's take a look further in these receptors. The mineralocorticoid receptors is found to be involved in CSC pathogenesis as identified in a study using a rat model. Aligned with this, in a human, we also found that the gene variant of NR3C2, a gene that encodes mineralocorticoid receptor, were associated with the increased risk for chronic CSC. However, these all findings are contrary to the Fiji randomized controlled trial because this trial showed an equivocal result that there is no effect of oral eplerenone as the antagonist of mineralocorticoid receptor. These all findings then indicated that mineralocorticoid receptor is not the main target of treatment in patients with chronic CSC. So to identify the underlying mechanism and get closer to human condition, we isolated and cultured human choroidal endothelial cells derived from postmortem donor eyes. This specific procedure allows us to assess the cortisol response and, for example, the role of different receptors to which corticosteroids bind. This picture here showed the complex layer of RPE and choroidal layer. In our experiment, we found that glucocorticoid receptor shown in a green label on the left image is expressed in the human choroidal endothelial cells. But in contrast, on the right image, mineralocorticoid receptor is scarce and only expressed within the neuroretina, which is not shown here. This immunofluorescence result exactly reflects our in vitro cortical response and the Fiji clinical trials that I mentioned before, in which the eplerenone treatment has similar results as the placebo treatment. Moreover, we evaluated the genome-wide expression upon cortisol exposure. We cultured choroidal endothelial cells from healthy donors and treated them with the cortisol. On the right side, as you see that all genes are almost perfectly aligned to the diagonal line between males on the y-axis and females on the x-axis. This means that males and females had a very similar cortisol response, although there is one gene, ZPTB16, that are highly upregulated in both sexes, and currently we are working on the functional implication of this gene. So despite the fact that we and others have found interesting genetic and experimental clues, much remains to be clarified with regard to CSC pathogenesis. For instance, why it is much more common in men and so strongly associated with steroid use. Therefore, this warrants further studies in both clinical and experimental levels for better choice of target of the treatment. In the experimental future perspective, laboratory study using a human model, especially choroidal endothelial cells and patient-specific model, will be useful to identify further the association of glucocorticoid receptor in the CSC pathogenesis. We can also use the model to assess the functional pathway of ZPTB16 or perform functional assay from human choroidal endothelial cells. This is hopefully giving a more clear information in the CSC pathogenesis. I would like to thank my colleagues and thank you very much for your attention. I will be, of course, willing to answer your questions during the discussion sections at the end of this course.
Thank you, Dr. Galuh, for this great overview. And the next speaker will be Dr. Gemmy Cheung from Singapore, who is currently sleeping because of the time differences, but we hope to be able to answer the questions with regard to her talk on the choroid and Central Serous Chorioretinopathy. She's an expert on this topic, and the choroid, as you probably all know, is really at the basis of CSC, it seems, and she's going to give an overview on that.
Thank you for the opportunity to participate in this EURETINA webinar, and I'm going to talk about the choroid in Central Serous Chorioretinopathy. The audience will be familiar with the choroidal changes in CSC, including thickened choroid, dilated hallux veins, as well as on ICG, the observation of a hyperpermeability. Several mechanisms have been proposed to explain the choroidal changes, including sympathetic disturbance, outflow obstruction, as well as formation of intervortex anastomosis. We recently evaluated the effects of systemic adrenaline on the choroid in a non-human primate model. These are serial OCT in one animal, and you can start to observe OCT changes at about week 6 to week 8. These changes include disruption and effacement of the ellipsoid zone, hyperreflective dots in the subretinal space, as well as shallow subretinal fluid. There was mottling on the fundus autofluorescence, and on ICGA, we observed hyporeflective dots, as well as surrounding hyperpermeability. Here are a few more examples of these ICG changes, which can be observed from week 4 onwards. These ICG changes are similar to what has been described in human patients with CSC, which has been suggested to represent choriocapillaris non-perfusion. We further performed quantitative assessment of OCT by binarizing the OCT choroidal segment and evaluating luminal versus stromal area changes. As you can see, there is a significant increase in mean subfoveal choroidal thickness at week 4 and week 8. This was mainly resulting from increase in area of vessel lumen, with a smaller increase in stroma. In the extrafoveal locations that we evaluated, there was also a significant increase in choroidal thickness, although the magnitude is smaller compared to the subfoveal region. In keeping with OCT findings, dilated choroidal veins and choriocapillaris were demonstrated on histology. To summarize this first part, we found that systemic adrenaline resulted in an increase in choroidal thickness throughout the macula. This increase was driven by an increase in choroidal vessel lumen, and in terms of the location, there was a most marked change in the subfoveal area. Now, this region is important and links us to the second part of this talk. As you can observe in the wide field ICG angiography below, the subfoveal area is usually void of these large Hall's layer veins because this area usually represents a physiological watershed between the 4 quadrants of vortex vein systems. Putting together the animal experiment and the clinical observation of dilated veins in the macular area and observations from wide field ICG, we have recently come to the suggestion and conclusion that these pachyvessel segments are not simply dilated vessels, but represent intervortex system anastomosis. Observation of pulsatile filling of dilated choroidal vessels, as shown here, further suggests and supports that there may be outflow obstruction and raised venous pressure. In fact, similar looking dilated choroidal vessels and anastomotic segments have also been noted in causes such as CCSF, where there is an obvious extraocular source of obstruction. So coming back to CSC, where could the site of obstruction be? This point was discussed in our recent review published in the Progress in Retina and Eye Research, in which we proposed that the exit site of the vortex vein through the sclera may act as a self-sealing wound and dictate the amount and speed of blood flow out of the vortex system. Hence, the scleral properties such as thickness and rigidity may also help to dictate the amount of flow and the susceptibility of an individual to develop central serous chorioretinopathy. So in summary, although we are familiar with the imaging findings in CSC, there are new ways to interpret these findings, with venous outflow obstruction being a unifying underlying mechanism. Sympathetic disturbance could be one of the early inciting factors, but with chronicity, we see remodeling and structural changes in the form of formation of anastomotic segments, thus explaining the pachychoroid appearances that we observe. And finally, scleral properties should be further investigated as one of the risk factors. Thank you.
Thank you very much, Dr. Cheung, for this perfect overview on the choroidal system. It's very intriguing that, that this seems to lie at the basis of CSC. The next speaker will be Dr. Elon van Dijk from Leiden University Medical Centre, who's going to talk about the diagnosis of CSC.
Dear Chairman, ladies and gentlemen, I would like to thank both the organizer of this course, Professor Boon, and EURETINA for the invitation to give a talk on the diagnosis of Central Serous Chorioretinopathy. I have no conflicts of interest. Central Serous Chorioretinopathy, or CSC patients, can present with a wide range of visual complaints, such as blurred vision, metamorphopsia, loss of color vision, and loss of contrast vision. On fundoscopy, subretinal fluid can be seen, which usually presents foveally. However, the differential diagnosis of CSC is very, very broad. After fundoscopy, the next step to make the CSC diagnosis is obviously an OCT scan. This scan reveals the subretinal fluid accumulation. In most patients, a thickened choroid is present, which is another key feature of CSC. Pigment epithelium detachments are present in the majority of patients. Then contrast images are needed, at least in patients with persistent subretinal fluid. As the origin of CSC has been hypothesized to be choroidal, a combination of fluorescein angiography and indocyanine green angiography is required. A hotspot of leakage on FA is typical for CSC, revealing leakage through the retinal pigment epithelium outer retinal barrier, whereas ICGA usually reveals hyperfluorescent changes. These changes on ICGA are often more widespread compared to FA abnormalities. To provide patients information on the prognosis and treatment options, a division should be made between acute CSC, chronic CSC, and complicated CSC. However, this classification is controversial and variable. The International CSC Classification Consortium is currently working on this topic. Acute CSC is defined as an acute onset, dome-shaped serous detachment of the neuroretina, in which the subretinal fluid usually completely resolves in 3 to 6 months, together with a good visual prognosis. Smokestack leakage on FA is characteristic of acute CSC. In chronic CSC, some patients have a single leak on FA, whereas other patients develop extensive RPE disease, sometimes with terrible atrophy, scarring, and intraretinal fluid. In this patient with chronic CSC, it is clearly visible that abnormalities on ICGA are far more widespread compared to FA. CSC may be complicated by a choroidal neovascularization. In this patient, subretinal fluid can be seen, together with a flat RPE detachment. There's leakage on FA, and there are hyperfluorescent changes on ICGA, characteristic of CSC. However, it is not clear if there is a choroidal neovascularization. In this patient, OCT angiography is very helpful, and it shows a choroidal neovascularization. Addressing risk factors of CSC is an important topic when establishing its diagnosis. CSC usually occurs in male patients between the age of 30 and 60 years. When the disease presents at an older age, this could be indicative of the presence of a choroidal neovascularization. Several genes have recently been identified to lead to only a slightly increased or decreased risk to develop CSC. It is therefore important to inform CSC patients about the fact that their male children only have a slightly increased risk to develop the chorioretinal disease. However, the most important of all clinical risk factors of CSC is hypercortisolism. The chance of developing CSC is up to 37 times increased in patients that use exogenous steroids and has been described to be independent of the dosage and the mode of administration of medication. Exogenous steroid use has been mentioned in as much as 52% of CSC patients. If possible, CSC patients should therefore definitely discontinue steroid medication. Endogenous hypercortisolism, or Cushing syndrome, which is the abundant presence of the steroid-like hormone cortisol, has also been associated with CSC. A full-blown textbook Cushing syndrome has typical clinical features and is easy to diagnose. These patients are overweight with a moon face, striae, and fat pads. Their skin bruises easily and has a decreased thickness. Patients with Cushing syndrome are often diagnosed with diabetes mellitus, hirsutism, and hypertension too. However, it is a challenge to diagnose the subclinical Cushing syndrome. We have published that CSC can be the first manifestation of a Cushing syndrome without the presence of other clinical features typical of this syndrome. This graph shows passport photographs of 3 patients over time, on which the subtle occurrence of a moon phase can be seen. Moreover, retrospectively, patients have several other complaints that could be typical of Cushing syndrome. However, only after the referral from the ophthalmologist to the Department of Internal Medicine, the diagnosis Cushing syndrome could be established. Ophthalmologists should therefore be aware of the presence of possible symptoms of Cushing syndrome in their CSC patients. To conclude, to diagnose CSC, you should never forget fundoscopy, also having a look at the peripheral retina to detect possible diagnosis that could induce fluid leakage. Moreover, multimodal imaging is essential and includes OCT, FA, ICGA, and OCTA. It is important to pay attention to the possible presence of both exogenous and endogenous hypercortisolism in these patients, as this is the most important risk factor to develop CSC. I would like to thank you for your attention and would be happy to answer your questions.
Thank you very much, Dr. van Dijk, for this great overview on the diagnosis of CSC. If you want to ask questions, please do so via the Q&A. So we will try to address as many as possible at the discussion at the end. And now it's my great pleasure to introduce my colleague, Dr. Suzanne Yzer from Nijmegen, who's going to talk about the very extensive differential diagnosis of CSC that is very important. Suzanne, please, the floor is yours.
Hello, everyone. My name is Suzanne Yzer, and it's a pleasure to be talking about the differential diagnosis of Central Serous Chorioretinopathy. I would like to start by thanking EURETINA for the opportunity, and especially Camiel Boon for inviting me to speak. I would also like to thank Brandon Strong for his technical support. In this talk, I'll be mainly talking about the differential diagnosis of neurosensory detachment. And the first case I'd like to discuss is this 23-year-old healthy male that was seen because of his itchy eyes, and the resident that saw him was very thorough, made an OCT, and this neurosensory detachment was seen. Additional imaging was performed, and this is very typical for torpedo maculopathy. The next case was seen at the pediatric department, and she underwent occlusion therapy, but her vision didn't really improve, and at one point an OCT was made, and this neurosensory detachment was seen. This is her fluorescein angiography, and not much is going on there. And we then had a closer look at her other imaging, and we found the dome-shaped macula on the vertical OCT. This is a 25-year-old healthy male that came in because of a drop in visual acuity in the left eye. He was then referred to me because of his neurosensory detachment, and this was pretty easy for me because by the time I saw him, it had completely resolved. However, taking a closer look at his fellow eye, I also noticed that this entire compartment seemed to be moved upward. And when I asked him about this, he said that he used ibuprofen at the time because he had pain in both his eyes, and this is posterior scleritis. The next case is a 51-year-old female that came in because of a central serous chorioretinopathy in her right eye in 2014 with spontaneous and complete resolution. She then came back because she also noticed a drop in vision in her fellow eye. And this is the image that was done, and you may appreciate the plaque that was seen on the ICG. This was actually the first case I made an OCTA on, and there's a very nice, very beautiful choroidal neovascularization visible there. This is pachychoroid neovasculopathy, and these patients need to be treated different than regular AMD case. So they are less dependent on anti-VEGF, and they may benefit from PDT when available. Pachychoroid neovasculopathy is a type 1 macular neovascularization. Patients show an increased choroidal thickness. There's an absent drusen. It's usually seen at a younger age. And on OCT, a double layer sign, a heterogeneously hyperreflective material can be seen in the sub-RPE space and some small peaked Ds. The next case is a 29-year-old healthy male who was also referred because of his nerve detachment. And on fluorescein angiography, almost looks like a smokestack there. ICG, however, we went on for a very long time, and in the late phase, you see the washout, and this is a choroidal hemangioma. This is about a 77-year-old male who was referred because of central serous. Now, this is already pretty old, and his vision was also pretty poor, I think, for central serous. He underwent PDT, he had anti-VEGF injections, and although subretinal fluid seems to change, it's actually the OCTs that were taking a different position. When I saw him, I also made a fundus autofluorescence, and I saw that it's very symmetrical, almost perfectly round in both eyes. And when I told him that I thought maybe something genetic, he actually asked me if it could be Morbus Best disease because both his mom and his son had gotten that diagnosis. Moving on to systemic diseases, this is a 43-year-old female. She came in because of a drop in vision in her right eye. In the left eye, there's also neurosensory detachment. However, there is some filling with deposits there. Looking at her fundi, there were android streaks in both eyes, and you may appreciate the peau d'orange. And this is an example of pseudoxanthoma elasticum. These patients need to be referred to additional specialists as well. And if you make this diagnosis in time, you can save a life. This 46-year-old male was actually published by Elon van Dijk in 2015. It's neurosensory detachment, some small intraretinal cystic changes as well. And this patient was treated with a MEK inhibitor because of metastatic cutaneous melanoma. The final case I'd like to show you is a 27-year-old female. It was an obese lady that was admitted to neurology because of sudden onset nausea and vomiting. She had paresthesia in her hands and face. She had pain in the epigastrium, an acute drop in visual acuity in her left eye, and these were her OCTs. Unfortunately, we couldn't perform any additional eye exams because she was simply too sick. But then we thought, sudden onset central serous chorioretinopathy in a very sick patient. She had hypertension, elevated liver enzymes, thrombocytopenia. We thought, could this actually be HELLP syndrome? Additional imaging was performed. I don't know why. I think there are easier ways to find out if a woman is pregnant. But indeed, this was HELLP syndrome. Labor was induced. She gave birth to a healthy son. And this is what her OCTs looked like a couple of weeks after delivery. So this was a very brief overview of the differential diagnosis of neurosensory detachment. If you'd like, so please remember this pachychoroid and neovasculopathy. Again, these patients need different type of treatments than regular AMD, and a correct diagnosis of central serous chorioretinopathy may save a life. If you'd like to do any additional reading, please look at the paper by Elon van Dijk and Camiel Boon, Serious Business in Progress in Retinal Eye Research. Thank you very much for your attention.
Thank you, Suzanne, for this great overview on the differential diagnosis of CSC, which is notoriously broad and can be quite difficult. We're going to discuss that later, I think, because there's much to talk about. The next talk will be on the role of photodynamic therapy in central serous chorioretinopathy. In the next few minutes, we're going to talk about the role of photodynamic therapy in central serous chorioretinopathy. Until recently, there was a lack of multicenter randomized controlled trials in central serous chorioretinopathy when it comes to treatment. But this has fortunately changed. I'm going to discuss several of them in this talk. We know that central serous chorioretinopathy is a retinopathy that affects the retina as a result of subretinal fluid accumulation and RPE changes. But we also know that the choroidal changes in CSC are presumably the primary problem, and choroidal changes are often much more extensive than the retinal changes, as you can see in this patient. There is a disequilibrium between the choroidal abnormalities, the choroidal flow and hyperpermeability that affects the RPE pumping function, that also disturbs the outer blood retinal barrier of the RPE. This equilibrium needs to be restored by treatment. What are the aims of treatment and the evaluation of efficacy? Well, first of all, I think it is very important to mention that you want to get rid of all the subretinal fluid, because then you can only really improve vision, because this will reconstitute the normal relationship between the photoreceptors and RPE, just as in this case. So after months and months, the photoreceptors regain their normal structural relationship with the RPE, with the reconstitution of the ELM and the ellipsoid zone when it's still not too late. And you also want to prevent or reduce the amount of recurrences by addressing the primary problem, which I cannot state enough, is the choroid. The evaluation of efficacy is subject to problems thus far, because many studies are retrospective and small with variable criteria. Controversial classification is important. Variable OCT parameters have been included. Visual acuity is not a good outcome measure, because baseline visual acuity in CSC is generally quite. A whole range of treatment options have been described in chronic CSC, but in this talk I will focus on photodynamic therapy, as it is the most proven treatment for CSC. But there are several other treatment options described, and these will be discussed by my colleague, Sobha Sivaprasad, in a subsequent talk. If you want to have a more in-depth overview about the available evidence and advice with regard to an evidence-based approach, you can have a look at this paper, which we published in an international group of experts, and which is available open access in Progress in Retinal Eye Research, published 2 years ago. Photodynamic therapy is treatment in which Visiodine or verteporfin is given intravenously in the arm. Then, after a certain time, with putting a lens on the eye, shining on the eye with a specific wavelength, this medication is activated in the choroid, and then it causes a remodeling of the choroid with reduced thickness towards more normal thicknesses, and then the fluid reduces, and eventually, in many cases, fluid under the retina disappears. Full settings have been used, but it has been found that if you use only half the dose or fluids or time, that it is still equally effective and possibly safer, although very few adverse events have been described also using full setting disease. It is also important to differentiate between acute and chronic CSC. So the single leak, very acute, typically in a younger man, have a different presentation and a different prognosis than chronic CSC. Because acute CSC often resolves spontaneously in many cases as an active visual prognosis. And in these cases, because of the spontaneous resolution that is often present, the good visual prognosis, is the question if you should treat. Well, when we look at PDT, which is, I think, by far the most proven treatment, we have found in a large retrospective cohort that the recurrence rate in PDT-treated patients was 4% at long-term follow-up, with in comparison 24% in untreated patients. And none of the patients actually developed chronic disease. And in a small prospective randomized controlled trial from 2008 in ophthalmology from Asia, it was found that the best corrected visual acuity was higher in the treated versus the non-treated patients, although it was even still 18% in controls, and equal or higher visual acuity than at baseline. And at 12 months, the persistence of subretinal fluid was 58. There was no subretinal fluid in 58 of the controls, but even much more, 95% of the patients who received PDT treatment in acute CSC had no subretinal fluid after a year. When comparing photodynamic therapy and micropulse laser treatment, this has finally been done in the PLACE trial by our group, in a multi-center group with several European centers, published in ophthalmology in 2018. It's available open access, and in this trial we found that half-dose photodynamic therapy was much more effective than micropulse laser treatment for chronic CSC, both with regards to a complete resolution of subretinal fluid, as well as functional parameters such as microperimetry. We also found in subsequent studies, which are listed below, that this is also the case in chronic CSC with focal leakage. So both in focal and diffuse leakage, PDT is superior over micropulse laser treatment. And also half-dose PDT was able to be effective after previous unsuccessful micropulse laser treatment, while this was not the case in patients who received micropulse laser after previous unsuccessful PDT. This was reported in the REPLACE trial publication in the American Journal of Ophthalmology, subretinal fluid. And with our group in the Netherlands, with Amsterdam, Nijmegen, and Leiden, we have also performed the SPECTRA trial, which was published very recently, also in the American Journal of Ophthalmology, which is available open access for you, in which we compared half-dose PDT actually to oral eplerenone treatment, and we found that half-dose PDT was by far superior over eplerenone treatment for chronic CSC. Again, if you want to read more about this, I refer you to these papers and also to this review paper that we published. And in this paper, we also gave a flowchart or a proposal for acute CSC management and also chronic CSC management. So why does PDT work best at present? Well, this is probably due to the fact that PDT has a more direct and rapid effect on the primary choroidal abnormalities, the subsequent RPE problem. And it is also most effective in a relatively rapid and complete resolution of subretinal fluid. Furthermore, we have found and also recently published that there are less recurrences after PDT. And there is a large body of excellent safety data, both retrospectively and prospectively. So there's no need to worry about potential risks of PDT, although there obviously has to be an informed consent with the patient, because there can be temporary decrease of vision in the first few weeks, which is always transient. The current problems and future perspectives are finally something to discuss. There's still a highly variable practice pattern. There are no large randomized controlled trials for acute CSC yet, though the chronic CSC randomized controlled trials clearly point to the fact that PDT is superior. But this poses also a problem because it seems that PDT is the only really effective treatment at present. And if it doesn't work, we don't have a good alternative treatment. More randomized controlled trials are obviously needed for replication. And it's also important to know that PDT is expensive. Hopefully, the trials that I described can help with reimbursement. And also, many of you know that Visudyne is currently on shortage worldwide. There is a production problem, which is only expected to be improved until in the first half of 2022, which is, I think, a very big problem which should be addressed. And hopefully, there will be more producers of Visudyne in the near future. So finally, we can say that current evidence strongly suggests that half-dose or half-fluence PDT should be the treatment of choice in chronic CSC. It is both the most effective and safe. And observation may be the preferred approach in acute CSC, but you could consider treatment in selected cases, for instance, pilots or people who are can benefit from a rapid resolution. Thank you very much for your attention. So after this short overview of PDT as a treatment for CSC, we go to the other treatments, many of them that have been described as a potential treatment for CSC. And Professor Sivaprasad from London is the next speaker. Thank you, Sobha, for being present.
Good evening, everybody. Today, my topic is other treatments for central serous retinopathy. These are my financial disclosures. First of all, it would be good to review why to treat chronic central serous retinopathy. Firstly, any treatment should cause complete resolution of subretinal fluid and also allow for timely preservation of the photoreceptors to enable improvement in visual function. The management should also prevent recurrences and prevent disease progression. Designing clinical trials in central serous retinopathy is challenging for several reasons. First of all, large proportion of patients have self-limiting disease. Secondly, the definition of chronic CSR vary, and so the eligibility for clinical trials also differ. Definition of duration of central serous retinopathy varies. Usually it's around 4 to 6 months of persistent subretinal fluid. However, even in this period, the OCT and the fundus autofluorescence may show differing patterns. Next, the subretinal fluid can also resolve spontaneously, although the patient has chronic CSR. So in short, chronic CSR is a heterogeneous disease, and the window of opportunity for treatment is actually quite limited. These particular points are usually not included in clinical trials in patients with CSR. Here I give you some examples of heterogeneity in CSR that are not included in clinical trials. For example, patients with AA sign are likely to harbor a CNV, but these are not an exclusion criteria for trials. Similarly, loss of subfoveal ellipsoid zone has no potential for visual acuity gain. Another example is atrophy that involves the fovea. All these are poor prognostic indicators, and we do not normally include them as exclusion criteria for clinical trials. So ideally, clinical trials for CSR should include a homogeneous group of patients with a potential for visual acuity improvement. And because of its remitting nature, clinical trials should always have a control arm, and the trial should be of sufficient long duration to evaluate the sustainability of the treatment. When we come to management of CSR, the first advice is to eliminate known risk factors, and that is to avoid steroids in any form, treat Cushing's disease or its like, Cushing syndrome, and also to, of course, reduce stress, anxiety, etc., because that also causes endogenous release of steroids. Now, coming to management, the first point is, what is the role of laser photocoagulation in central serous chorioretinopathy? Laser is done to seal the extrafoveal focal leaks, and several lasers have been tried to cause a resolution of these leaks. However, there has been no data suggesting that influences disease recurrences, and it also does not influence the choroidal thickness, which is the primary pathology for CSR. It may cause an immediate resolution of the subretinal fluid, but the effect on visual function may be slow or minimal. So in short, the evidence on the role of laser photocoagulation in CSR suggests that laser is not an effective treatment for this condition. And the best trial we have in place at present is the PLACE trial that it's an RCT that compared ICGA guided 810 nanometer high density subthreshold micropulse laser with half dose PDT in patients with chronic CSR. And as you can see, and as was mentioned in the previous talk, the half dose PDT was superior to the laser treatment, both in the short term and the long term. In all three parameters, that is resolution of subretinal fluid, increase in best corrected visual acuity, and improvement in retinal sensitivity. What about the role of eplerenone in chronic CSR? Again, we have two trials. The Vichy trial compared eplerenone versus placebo for 12 months in patients with chronic CSR and found that eplerenone was no better than placebo. Then we have the SPECTRA trial, which compared half-dose PDT versus eplerenone for 3 months, and then it became a crossover trial. At 3 months, 78% of patients in the PDT group had complete resolution of subretinal fluid compared to 17% in the eplerenone group. Clearly, PDT had an advantage over eplerenone. There are several other pharmacological agents that have been tried in CSR, and I've got a list here for you. However, the evidence for any of these is very limited. There are no clinical trials that are well designed to compare any of these agents versus placebo in chronic CSR, and therefore these are not advocated either. The next question is, what is the role of anti-VEGF in CSR? It should only be applied if there is a CNV with the presence of a leak, that is an active exuding CNV. That's the only point when we give anti-VEGF for in patients with CSR due to CSR CNV. And there are instances when you will see an inactive choroidal neovascularization in patients with CSR, and we do not treat them with anti-VEGF, and there is no evidence that anti-VEGF given in such circumstances will be of any use to the patient. And there is no role of anti-VEGF in patients with CSR without CNV. So in conclusion, PDT remains the mainstay for treatment of chronic central serous chorioretinopathy. All other interventions to date do not provide us with sufficient evidence to use it in clinical practice. Thank you. Good evening, everybody.
Thank you very much, Sobha. Are you still here?
Yes.
Thank you so much for this wonderful and comprehensive overview. And it's a great pleasure to have you here after, even though your train was giving you problems getting home. Thanks so much for being here. Well, we've got a lot of things to discuss, I think. So let's quickly switch to the discussion. We've received quite a lot of questions, several on the same theme, many on the treatment. But I think it would be nice to first start with questions on the diagnosis. One of the questions asked was, what is the role of OCTA in diagnosis of CSC? Elon, could you say something about that?
Yes, of course. So I think there are many patients in which there is any doubt on the presence of a choroidal neovascularization. So even if you use the combination of OCT, FA, and ICGA, still there is doubt. Then OCTA can be very useful in order to see if there's a choroidal neovascularization, because when there's a neovascularization, anti-VEGF treatment is needed, where when there's no neovascularization, that won't be needed. So I think that's the most important reason to perform OCTA.
Yeah, thank you. And I still have quite some difficulty with interpreting OCTA. Suzanne, what is your experience with that? Can you easily identify them?
I was just about to ask you all as a panel, if you make an OCTA in this case and you find a choroidal neovascularization, how do you differentiate between the fluid that's there? Is that secondary to the neovascularization, or could it still be a central serous there? I don't know how to differentiate these cases.
Sobha, do you have some insight on that?
I mean, it's an excellent question, Suzanne. So what we tend to do is to compare from previous photographs to give us a clue whether this is the subretinal fluid is increasing. A double layer sign is a very good sign to show that it is actually CNV. But I can understand a CNV can still be there, not causing trouble. The other point is if there is an intra.
Oops.
That is a CNV rather causing trouble.
Sorry, Sobha, your last two sentences, I think they disappeared. So could you repeat the last part of your answer?
Yeah, so if there is a double layer sign with subretinal fluid and intraretinal fluid, I would definitely think that is due to the CNV rather than due to the CSR. But I know it is very difficult. Even in the presence of CNV on OCTA, it is always challenging. You need to look at serial photographs before you can decide. Yes, I agree. And also OCTA is quite vulnerable to artifacts. So even looking at OCTA, I think is still a learning experience in these relatively early days. But what I personally use when trying to differentiate or trying to see if there's also a CSC component is when I look at the spectral domain FFA and ICGA, if there are also points of focal leakage and also more extensive ICGA changes reminiscent of pachychoroid or CSC, then I also suspect that there may be a more CSC component in addition to neovascularization. Another question in terms of diagnosis is there any relationship between CSC from Dr. Torres, any relationship between CSC and allergies that could cause or worsen sleep apnea? Because sleep apnea has been associated with CSC in studies, several studies. So what do you think about that? Elon, could you comment on that?
Yeah. So what Professor Sivaprasad already mentioned is that there could also be a relationship between sleep apnea and cortisol levels. So maybe we're more looking at the cortisol levels than the other problem could be. But yeah, I think that's the most important point to mention.
Good point. Would there also be, Suzanne, a role for the choroid or congestion of the choroid when it comes to sleep apnea? What do you think?
That's a good question. I never really understood the relationship. So I know it's there. I always ask it to my patients. I've never found one patient with sleep apnea and central serous chorioretinopathy. So I know it from literature, but I don't really understand how it works.
Okay, thanks.
Maybe someone else from the panel has an answer, but...
No, there was a mechanism that I could think of, but I'm not sure.
Maybe when it comes to the allergies, it's about the use of steroids in those cases. That would also be a possibility.
Yeah, exactly. And what about the timing of, well, because I think many of the questions were on treatment. So when switching to treatment, when would you decide to start to treat? Sobha, would you maybe comment on that?
Yeah, I think we should try and treat patients early. So between 4 to 6 months, if you can define when they started, I think it should be 4 to 6 months. But in clinical practice, I should confess that we usually start PDT very late in the course when there is already photoreceptor loss, as you see on the ellipsoid zone, or you just feel that less atrophy coming in already, and then we try to do PDT. Of course, the fluid will go away in those instances as well, but the visual acuity will not improve. So I think, as I said in my earlier talk, the window of opportunity is when you see, in my eyes, a white hyper autofluorescence on CSR, on autofluorescence. I think that's when you really should try to apply the PDT rather than allowing it to go to hypo autofluorescence when I think we have lost the battle there.
Yeah, I think in the Netherlands we are very much into PDT and CSC when it was still available. Yeah. And Suzanne, we treat much earlier, right? Could you comment on that?
Well, what I do is, in the ideal world, when we have Visidyne available, I would observe about 2 to 3 months, and then apply PDT. So I'm not going to wait even for 6 months or longer. I treat early, and one of the studies that Camiel, you also showed by Daniel Moabati, is that we saw that the patients that we treated early had less recurrences. So I really think there is also evidence-based reasons to treat early.
Yeah, I think we're all talking about the studies that we did together, Suzanne, is on severe CSC. It seems that it can still respond to PDT, as Sobha also suggests, but with the atrophic changes, you're a bit too late. The visual acuity can improve, but the baseline acuity is already quite poor.
And also, one of the things you mentioned is that these acute cases, they don't really evolve into chronic. So I think we're looking at possibly two different disease mechanisms. So, you know, some of these chronic cases, they come in so late, there's already so much hypo autofluorescence there when they first come in.
Yes.
And I think the combination of duration of complaints and also findings on multimodal imaging quite in the early stage are important, because also when there are only complaints for a few weeks, there can be quite a lot of signs of chronicity of disease, which could maybe induce treatment earlier.
Yeah. Now that we're talking about the elephant in the room, that's the lack of Visidyne at present, because there is only one factory in the whole world making this Visidyne, and this factory is not making it right now because of a problem with the machine, apparently. So the whole world is waiting on Visidyne. Several questions came up. When can we expect that Visidyne is on the market again? People think, as mentioned in my talk, that it may be the first quarter or first half of 2022, but this is still quite uncertain. At that moment, when they start production again, there will be a huge demand in all the world. So it is really hoped that there will be more factories trying to make this stuff, but many of them are hesitant because they are not sure if they can also compete on the market, because there will be a restart of the production, hopefully, but we're not sure. So this is really causing us a lot of trouble.
It's very complex to produce. It's not something your own pharmacists can do.
No, that's right. Well, there are many more questions. Another question was safety when the fovea already has some atrophic changes. Can you also treat the fovea even in those cases? I think there's quite some evidence now from several groups, including ours, that it is safe to treat the fovea, certainly. and also that we have some recent evidence that we're still on the verge of publishing that it will not increase atrophy when it's already there in the fovea. But now I think we should talk about alternatives. Yeah.
Yeah. So I was wondering, like, I absolutely think it's safe to perform PDT centrally or in the fovea even. But now when we don't have PDT, how would you treat a central serous case that has a small leak, but it's very close to the fovea?
Well, I think I have my own opinion, obviously, but I would also pass the question partly on to the others, and especially Prof. Sivaprasad. So we know from this excellent Vichy trial from your group, Sobha, that eplerenone really doesn't seem to work. There are some mentionings of subgroups where it might work, but this is all very poor retrospective evidence. What do you think about spironolactone, Sobha? Would that be an alternative?
Yeah, I also saw those questions, and the Vichy trial did not even give a bit of signal. So I'm very reluctant to state that you could try in a subgroup. I don't even know what subgroup it was because we really looked through everything and couldn't find a subgroup that could benefit from it. Now we are in a global challenge now. We don't have anything to offer the patients. It's eplerenone is as good as placebo. Now, if these patients are really stressed and eplerenone acts as a placebo for them to cause a resolution of fluid, no harm giving them, but they need their potassium monitored. But I don't believe that there is any effect of mineralocorticoids antagonist for CSF.
One of my personal favorite findings in your Vichy trial is the fact that you found a 30% complete resolution after 1 year in the placebo-treated patients, which
Correct.
also points to the fact that retrospective studies are inherently very flawed in general in CSC. So yeah.
That's exactly right. So I would definitely encourage anybody doing an RCT to have a placebo arm as well, because
yes.
It is such a heterogeneous disease, and we may just report things wrongly if you don't have a placebo arm.
Suzanne, could you comment on laser? Just the good old focal laser. When would you perform that especially now that we don't have PDT?
Yeah. So in the ideal world where I would have PDT, I would only use PDT. But now that I don't, I tend to use it for extrafoveal leaks. It's of course it's like a seal. It's not attacking the problem like we do with PDT, but it's, I think, the best alternative that I have at this point.
And would you even treat leaks in the papillomacrylary bundles as long as it's a bit far away from the fovea? Would you treat that, Suzanne and Sobha?
Well, in these cases that have had subretinal fluid there for 6 months, I don't know for how much longer I can wait for so many photoreceptor loss that it's causing irreversible visual acuity loss. So yes, I would do that.
Yes. Sekar, could you maybe comment on the fact that mineralocorticoid receptor antagonists don't seem to work, just before we close the session? Why do you have experimental evidence to explain why that is the case?
Well, in that case, there's a previous study that Elon van Dijk already performed that there are some genetic variants. The NR3C2 gene is increased at the risk of CSC. And so if people have these variants, and then there are also another people that have these less variants of these, then probably that eplerenone doesn't work. But then also there's also another evidence that we also saw in the primary CEC that published by Yo Springs that we don't see the presence of MR. So it's still not a fixed answer.
I think that's quite an interesting finding, that you didn't find the mineralocorticoid receptor that much in the choroid, while you did see a lot of glucocorticoid receptor present. Because of the time, we have to wrap up. It was a very nice discussion. I think I enjoyed it a lot. Time flies, so we have to wrap up. And I think that we discussed some interesting and important insights, both on the pathogenesis, diagnosis, differential diagnosis, and treatment. It is clear that there are a lot of uncertainties still regarding CSC, so we need more research from all of you, all of the people present in this mysterious disorder, and I think we're working hard on that to further advance this knowledge. A large, big thank you to all the speakers for their excellent contributions, for EURETINA for organizing this wonderful webinar, and thank you as all attendees for your presence here, and we're looking forward to see you again in the future. Thank you.
Thank you.